certainly our second-line options depend on what patients have had in the front line. And in the frontline setting, we have a number of immunotherapy-based combinations that are approved and standard. So in the second-line setting, we often depend on VEGF inhibitors that patients have not received in the frontline setting. And also there's some combination data that are now coming out. More specifically, we've now had 4 trials, they're phase 2 trials that have shown a lack of efficacy of adding ipilimumab if patients are progressing on nivolumab alone. So I think that's an important data point for our patients. So not to follow with adding ipilimumab. And then we also have multiple VEGF inhibitors that are proven in the refractory setting. So these include cabozantinib from the METEOR trial, axitinib from the AXIS trial, and also now tivozanib from TiVo-3, which is the only trial also in the current immunotherapy era where many of those patients were refractory to frontline immunotherapies. I think what's exciting at this meeting is that there is a phase 2 trial being presented by Dr. Albiges from France and her colleagues on sequencing cabozantinib in the immunotherapy refractory population. So we're excited to see the data from that. But certainly there are many agents that are active still in refractory populations, and we are also now seeing some important early phase studies that have shown some signals in terms of efficacy for refractory renal cell carcinoma. There are multiple VEGF IO combinations that have shown efficacy in the IO refractory population. So these include lenvatinib with pembrolizumab, tivozanib with nivolumab, and cabozantinib with atezolizumab. Of these, there are 2 now in phase 3 testing. So tivozanib with nivolumab is ongoing in TiNivo-2 study, and then also cabozantinib with atezolizumab is ongoing in the CONTACT-03 trial. So those will certainly help us define refractory IO-based treatment combinations. In addition, we've had some early phase 1 data that seems quite promising as well. So there was a bispecific antibody targeting both CTLA-4 as well as PD-1 that was presented at ASCO last year. And so that one has a really interesting efficacy profile, and we're excited to see it roll out into further phase 3 testing. In addition, there's a CAR T-cell that Dr. Powell presented at SITC last year that was a CD70-directed CAR T-cell. So as CAR Ts have made an impact in hematologic malignancies, we're hoping that it will also reflect and make an impact in solid tumors as well. So there were quite a few partial responders in his cohort, and I'm hopeful that these treatments may present viable options for our patients in the refractory setting. Right, so our treatments really range. So in the refractory setting, all of the treatments are available. So you could have a patient progressing on ipilimumab, nivolumab in the frontline setting, receive cabozantinib, and then as they're progressing, still be eligible to receive lenvatinib, everolimus as standard of care, still be able to receive tivozanib in the 4th line setting, and also to think about clinical trials, obviously in the refractory setting. And so as we learn more about immune checkpoint refractoriness and resistance, we will be better able to develop therapeutics that target those mechanisms of resistance. There are multiple frontline setting trials that are ongoing. 2 of them are being run in the cooperative groups. So one of them I'm fortunate to run. It's a study called Pedigree, which takes all patients with takes all patients with intermediate and poor risk disease and treats with 4 cycles of ipilimumab and nivolumab, and then randomizes them depending on their disease response to either nivolumab alone or nivolumab with cabozantinib. So that's kind of a sequencing approach. There's another trial that's open in the NCTN groups called PROBE. It's a question of who should receive cytoreductive nephrectomy. So these are de novo metastatic renal cell carcinomas that there's a question of when and how in the patient population that benefits from cytoreductive nephrectomy of their primary tumor. So the trial is randomizing patients after 3 months of immunotherapy treatment to nephrectomy versus not, and continuing on systemic treatment. So that will also add to our understanding of early disease in de novo metastatic renal cell. And then finally, there's a couple of triplet trials that have helped us understand the role of triplets in the upfront setting. The first of which is COSMIC 313 that read out in October of 2022. And the second, which is ongoing, it's a trial called LIGHTSPARK 012 with a combination of lenvatinib, pembrolizumab, and belzutifan, as well as lenvatinib, pembrolizumab with quemliclustat, which is the CTLA-4 inhibitor, versus lenvatinib with pembrolizumab on its own. So I think all of these trials will help us further define treatment options in the frontline setting.